Sorry, okay. I have mute myself. So, hi, thank you so much for having me here. I'm really excited to be here with you guys, and I think that this organization is amazing, especially with everything that's going on. And I know how difficult it is right now to have shadowing experience. So I'm really happy that you guys started this, and I'm really happy to share a little bit of my experience on my journey to PA. So let me share my screen. I have a presentation for you guys to help share all this information. Okay. There we go. All right, you can see that? Yep.
Yep, looks good.
Okay. So yes, my name is Gabriella. I like to go by Gabby. I am a new graduate physician assistant, and I'm working in family medicine. I am also a certified diabetes educator and a registered dietitian. So we're going to talk a little bit about each of those credentials and my journey to or through all of that, I guess, and then my experience now as a PA. So I guess that's this. This is the outline. We'll talk about my timeline, my credentials, why I chose family medicine, kind of a day in the life considering this, let's see, not even 3 months into practice yet, but this is what it is so far. And then I have a few case studies for you guys as well. So as far as my timeline, I am from Venezuela, so my first language is actually Spanish. I started my undergrad back home, and then back in 2011, I transferred to Florida International University, and I did that as an undergraduate or international student, and I finished my undergraduate in nutrition and dietetics. At that point, I wasn't really looking for a career in medicine as a physician or as a nurse. I didn't even know about the PA profession, so that was not in my radar at all. I really did enjoy healthcare and nutrition and being able to work with patients and help them through their conditions. So I found that nutrition was a good way to do that. If you are familiar, if you've been at the hospital or have done, some research in different health professions, dietitians work at the hospital too, and they're a very important part of the team as well. So I thought that was a great way for me to join the healthcare team. So I graduated undergrad in 2014, and that was including all of my didactic portion, so all of the class and coursework, I guess, plus an 8-month internship that we have to do in order to become registered dietitian. So then 2015, I got my first job as a diabetes dietitian. So I was working in a diabetes during pregnancy program. And then 3 months into my job, I took my RD exam and passed. So for the dietetics credentialing process, some jobs will allow you to start working and take your exam within the first 3 to 6 months, depending. At least that was the case 5 years ago. I'm not sure if that's still the case. But that was a beautiful job I had because I was working with pregnant women that had diabetes, diagnosed in the pregnancy, as well as pre-existing diabetes, so type 1 and type 2. And even though I wasn't looking to specialize so early in my career, I'm very thankful for that job because that's when I found out about the PA profession. So a couple years later, when I was working there, I became a CDE, which is a certified diabetes educator. And around that time, I was starting to feel a little bit limited in my scope of practice and what I was able to, do and help my patients. So I started looking for ways to expand my scope of practice. So I looked into nurse practitioner and PA were really the options I was considering at that time, because again, I never really had that desire to become a physician. So, and also I already had my bachelor's, I already had a career. I wasn't really interested in going back to like med school and all of that. Plus, I really like the flexibility I had, at least as a dietitian, to work in different fields. So as a dietitian, I was working in diabetes, but I also had plans to work in dialysis. I could work as an inpatient dietitian. So I wanted to keep that flexibility. So then that's why the PA profession, that was one of the main reasons why the PA profession really appealed to me. I did a little bit of research, rather a lot of research, and I met some PAs, I shadowed PAs. So pretty quickly, as you can see, that was from 2017 to 2018 when I started PA school. So I made my decision in all of 2017. I really put a lot of effort in taking all of the prerequisites I needed to shadow and learn more about the profession, get some volunteering experience that was current because my volunteering hours were from undergrad. So that was like 3 years ago at that point. And then that's when I had to study to take my CBE exam. And I did all of that while working full time as a dietitian. So it was a very hectic year, but it really prepared me to, be able to handle PA school, which is also very demanding. So then 2018, I started PA school, and this year, 2020, I graduated PA school in August, and I took and passed my PANS at the very end of August. So that was just 2 weeks after I graduated. And I started my job in family medicine like 5 days or so after I took my PANS. So it was all pretty fast at the end. I guess throughout all of it, it was pretty fast. So let's talk a little bit about those credentials and a little bit more into the journey. I kind of said a little bit about this already, but I wanted to become a dietitian because it was a career, or it is a career in medicine that offers high level of involvement in patient care. Well, high level, it's kind of controversial, I guess, because I ended up switching careers to expand that scope of practice. But these are my initial thoughts, let's say. You are part of a multidisciplinary team. There is a huge focus on health promotion and disease prevention, which I am very passionate about. And like I said, we can work in different areas, and not only clinical, but also outpatient, private practice, food service, with pharmaceutical companies and food companies. So a lot of different areas, and it really offers a good work-life balance. So it just seemed like a great career at that time. This is a little bit more into what goes in becoming a registered dietitian. So you have to go to school and get your bachelor's degree at accredited program, and then complete the internship. That has to be, again, accredited by ASCEND, is the organization that takes care of that. And it usually is about 8 months. Some of them go a little bit more like a year. And then you have to sit for a national exam and keep up with CME credits. So again, I went over this a little bit already. Where do RDs work? Lots of different areas. For me, like I said, I wasn't really planning on specializing. I wanted to start working in the hospital and be a inpatient dietitian. I really enjoy doing TPNs, which is a calculation for total parenteral nutrition. If you guys have or are familiar with that at all, that is something that the dietitians usually do at the hospital. It's really cool. And then, yeah, so I was just offered this opportunity at a diabetes program. And I also was offered a job in WIC, if you're familiar with that. That's a women's and infant health program. So they have dietitians in their teams, and they have nutrition or nutritionists, which there's a difference. And I think I have a slide in that. No, but going back to this, the difference between registered dietitian versus nutritionist is usually a nutritionist really can be anyone that takes a class in nutrition. or like, health coach or something like that, that there's a little bit of nutrition, you can call yourself a nutritionist. But to be a registered dietitian and nutritionist, so all of that, this is what you have to go through. So I always, make a little clarification about that, because our credential used to be just RD without the N, and they changed it to make that clear, I guess. So this is what I did at my job as a dietitian. I was doing a lot of diabetes education, group classes, and one-on-one. I did medication education also. So I would teach patients how to use insulin, how to manage their blood sugars. And as time went by and I gained more experience and a lot of privileges with the supervising physicians I had, I was able to, and then when I became a CDE as well, I was able to start patients on insulin on my own and manage their own, their insulin based on my assessment of their blood sugar. So really, that's when I started to look more into medicine and becoming a full healthcare provider that, that I would be able to take care not only of their diabetes, but their other health issues. Because I was getting a lot of questions from patients about, maybe their pregnancy and their hypertension and other things like that. And I always had to refer them back to their provider, because my job was just to help them take control of their diabetes. So more into that, my other certification is in diabetes education. We also have a new title. Lots has changed since I started, and that wasn't even too long ago. The new title is Certified Diabetes Care and Education Specialist. And I have a feeling that in my, career, my time as a PA, the PA name might also change. So all of the credentials I go for, they all change their name at some point. But who can be a CDE? Basically, a lot of healthcare providers can. So nurses, dietitians, pharmacists, PAs, MDs, VOs. The requirements are to have at least 2 years of experience working in that profession, and then have 1,000 hours of diabetes education. And this, for me, that was pretty easy because that's all I was doing. But also, for someone that maybe works as a PA or an MD or a nurse, where you see some patients with diabetes, but you're not constantly giving diabetes education, 8 hours a day, 5 days a week, that might take a little bit longer. Keep up with diabetes related, CMEs, and then you sit for an exam again. So this is kind of the topics that they cover in the exam. And then after that, you keep up with some more CMEs, and that's how you keep your credentials. So throughout that, those first 3 years of me working, I had this new goal, which was to become a PA. Why did I do that? Like I said, I was looking for a wider scope of practice with still flexibility in terms of which fields I could work in. So that was my lateral mobility that the PA profession offered. The level of autonomy. So this is a little bit controversial, I guess, because this varies by state. I am in Michigan, and Michigan is really a very friendly PA state. It's one of the best states to work as a PA because we have so many, such a good organization working towards improving legislation, I guess. There are still things that don't make sense, like PAs cannot write for diabetic shoes. Well, why not? Why can I start my patient on insulin, but I cannot give them diabetic shoes, So things like that. But in terms of autonomy, PAs are usually very autonomous. We do have to work under a supervising physician, but that doesn't mean that the doctor has to be physically there overseeing everything you do, or looking over all of your charts, or that you have to check with them on every single patient, which is where I say this varies by state, and it also varies by specialty. Where I was working before, so I was part of the OBGYN department, we had a PA who, she had her own clinic. That means like her own patients that she would see, but she typically did have to discuss cases with the supervising physician. And then she was also part of the high-risk clinic. In those patients, she 100% had to go present to the supervising physician before she can let go of the patient. So it was different there. Like I said, it just varies by specialty in state. And then I really like the collaborative work environment. I already had experience working with a supervising physician, but I still had some level of autonomy within what I was doing, which was diabetes education and blood sugar management. And so as a PA, that's kind of an extension of that experience, because again, I would have some autonomy, but I would also have a doctor available if I had questions or, to discuss cases and things like that. And then ultimately, again, it's controversial, I guess you can say, but it's a work-life balance. At least it's the idea. I think it really goes tied to the lateral mobility and, PA, the ability to just work in different specialties with different schedules. Now, that doesn't mean that PAs always work less than the doctor, for example, because that's not true. There are many PAs in different specialties that work probably as much or more hours than the doctors do. So take that with a grain of salt. But in general, you can find great jobs with, great schedules and things like that. At least my personal decision, one of the things was that as a PA, if I ever wanted to work part-time, because let's say I become a mom, I would be able to still have a good income and a great job and work part-time. So that's kind of where I was going with the work-life balance when I first made my decision. All right, so moving on. Okay, well, I have this here. This is basically what a PA is. Probably you guys are familiar, but we can diagnose, manage, and prescribe. We are extenders of the physician, right? So typically we would do all the same things as a physician. That's based on, if I work in family medicine, my scope of practice goes as far as my supervising doc. So I'm not gonna go do like a lumbar puncture, because that's not what we do in family medicine. So within that, environment, but we are generalists. We are trained in pretty much in a lot of different fields in medicine. So that allows us to work in different fields. And this is what you see here. We're in primary care, internal medicine, emergency, subspecialties, surgical subspecialties also, as well as different settings, so outpatient, urgent care, hospital. And that's a really cool thing, because this helps patients also, it helps increase access to healthcare, I guess it's where I'm trying to say, which it's ultimately what we all want, for patients to be able to get the care they need, at the time they need, I guess. So what does it take to become a PA? You have to have a bachelor's and meet the minimum course requirements, so all the prerequisites. This is another reason why I went for PA as opposed to NP. It's because I already had a bachelor's in nutrition, and usually to become an NP, you have to have a bachelor's degree in nursing and have experience as a nurse. So I was not about to go back in time and do all of those things. I really wanted to kind of do all of this as quick as I can, so I could go, study, do my degree, whatever I needed to do, and then go back to work as soon as I could. You are going to need, in order to apply to PA school and be a competitive applicant, you're going to have patient care experience. This varies by school, in terms of what kind of experience they allow. Shadowing hours are not always required, but are highly, highly recommended, because it allows you to understand better what a PA does and how it varies from specialty. So for me, I shadowed emergency medicine, urgent care PAs, the OBGYN PA, and an OB triage PA. So that helped me understand better what a physician assistant does and their scope of practice. You're gonna need volunteering hours, leadership experience. So for me, I volunteered. I always recommend, volunteering things that you enjoy. And if you can, that they are also health related. So for me, I sign up for a few different nutrition education programs in the area. And then as far as leadership, I didn't have a lot in the years like when I was working, but in undergrad, I was part of a few different student organizations. I was the co-founder of a Venezuelan student organization. And then I was a representative also for our state, or not the state, but for the Miami Dietetic Association. So that was some of my experience there. You then will need to apply to an accredited program with a CASA application. That's our centralized application system. You might need to take some exams like the GRE, the PA-CAT, and some other things I guess that are coming. I'm not very familiar with the newer forms of exams. You'll need a personal statement. Whoops. And then what happened here? Oh, I knew I had this here. This is more into what my experience looked like. And then let's see. Letters of recommendation. Then the program is usually 2 to 3 years, and then you sit for the PANS. That's your licensing exam. So this is kind of how it went for me. My program. Well, I guess I applied to 2 programs. My first cycle, I had 1 rejection and 1 interview that I was accepted to. It was a 24-month program, but this program also offered a 3-year path and a 5-year path, which they don't advertise it a lot, and I'm not really sure why, but they have a bachelor's to master's program, I guess. So you can graduate high school and start this program. You go through 3 years of undergrad and then 2 years of PA school, and you graduate, which is really cool. And then there's a 2-year program, which is a full-time 24-month program, and then 3-year program, which means that the first 2 are part-time, and then the 3rd year is the clinical year, so that is full-time. So when I graduated mid-August, and 2 weeks later, I took my PANS, which is why now looking back, I really recommend doing it that way because the information is still really fresh, and the sooner you use it and you're still like in the mood of taking exams, I guess. So it makes it a little bit easier than if you waited longer, in my opinion. Okay. Sorry, I'm not sure what happened. Stop it. Okay, internet. I'm sorry, guys. Can you, okay, I can even find my thing. Where did these go? Okay, here we go. Okay. So, this is just a little, I don't know, inspiration maybe that I have for you. It's never too late to follow your passion and go after your goals. Your goals can change as time goes by, and that's fine. Just don't stop until you're proud, and then keep going. Why is this doing this? Thing is acting up. I'm not sure what's going on. So then I became a family medicine physician assistant, and I am really happy. I like it a lot. Every day is different. Why did I choose family medicine? Well, when I was first applying to PA school, I had in mind that I could work in specialties like endocrinology, OBGYN, and family medicine. And that was basically because that's the experience I had, right? That's where I started working, and I already had that background. So I felt that my skills would be better utilized in those areas. But then as I went through my rotations, I found out that I liked, oh, the other thing is when I was a dietitian, I did not do I basically almost never touched my patients. I would only touch my patients to do a blood sugar test, nothing else. I had no physical exam. I mean, there are things that you as a dietitian can do in terms of physical exam, because nutrition deficiencies show up in different ways, right? Symptoms and signs. But we don't really do a whole lot of physical exam or procedures or anything like that. So I was really kind of afraid that I maybe would pass out when I went through surgery, or that I would just be really bothered by procedures like INDs and pap smears, or I don't know, things like that. Well, I went through my rotations and I found out that I really enjoyed procedures. I had an urgent care rotation that was really cool. And I also had an interventional radiology elective rotation where it was very, very hands-on and it was amazing. So the fear that I had before starting PA school was nonsense because I love procedures now. So family medicine, I chose it because we see patients from babies. I've seen, no, I think the youngest patient I've seen, he was maybe like a week or two old, to elderly. So the whole spectrum of ages, and we see and manage a lot of different medical issues from, chronic conditions like hypertension, diabetes, arthritis, and also minor or less chronic conditions as well. And then we do minor procedures in the office. So things related to women's health, pap smears and pelvic exams, breast exams, INDs. We do rectal exams. I will tell you a little bit more about it when we go over a day in the life, but there is, again, a huge focus on patient education, which I love. And because of my background as a dietitian, I like to think, but I take pride in it too, because I'm very good in patient education. There is also autonomy within the family medicine as a PA, and really it has good hours. So my schedule right now is Monday through Friday. I get to the office sometime around 8:45, and I'm usually out somewhere between 5 and 6. On occasion, it's been like 6:30, but that's rare. Oh, here we go. So I don't know why I'm jumping ahead on every single slide, so sorry. So yeah, I get to the office, usually ready to see patients, or sometimes I spend a little bit of time looking over lab results or finishing charts from the day before. I see about somewhere between, when I first started, somewhere between 10 to 15 patients a day. I think now I'm probably seeing more like somewhere between 15 and 20 patients a day. So at one point in time, if you stop me during my workday, I could be seeing 2 to 3 patients at a time. And so this time between 9 and lunch break, I go to room 8 and I'm maybe seeing a 21-year-old with complaints of heavy periods, and that she's had her period for the past 2 months. It hasn't stopped. She's also having blood clots. So we're working on that. I need to order some blood tests. We're going to have to do a pelvic exam, see if we can do a pap smear. So my MAs are going to be setting that up while I go see maybe a patient in room 5 who is a new patient that might have a history of hypertension and diabetes, obesity, arthritis. Those are like the things that I see most often. Maybe also some eczema, some alcohol issues. So I go in there, we talk a little bit, get all the history, see, go over their medications. This is all what they're setting up the other patients. I'll order maybe some exams, so blood work or chest x-ray or EKG. Oh goodness. I'm sorry, hold on. Resume. Okay, here we go. So I might, order some more studies and imaging, well, things that we can do in the office. And then I'll come out, and if my pelvic exam and pap smear was ready, I would go and do that. If not, then I go on and see another patient. So sometimes that could be a little bit of a faster visit, like med refills. So that could be hypertension and all of their blood pressure medications or their pain medications, their insulin. I do a lot of diabetes and blood pressure follow-up, so that those appointments sometimes are a little bit faster if all we're doing is checking their blood pressure. If it's diabetes, it goes a little bit longer because I do, again, a lot of education. So it's not just about adjusting their medication. So for example, I had a patient recently who their A1C had gone up in 3 months. It went from like 8 point something to about 9.5, a whole point. So we started talking about it. I said, what do you think is the cause for this sugars going up? Did your medications change? Did something in your life change? Well, sure thing. He had had some family issues. Then he also said the holidays, are hard. And he's also been drinking a little bit more alcohol than he normally does. So then we have to talk about those things. I said, well, listen, instead of me giving you another diabetes medication, why don't you take the next 3 months to clean up your diet? And, we're going to get over the holidays. We need to stop the drinking because that is also messing up with your liver. And then we check again and we see if in 3 months we're not any better and we're worse, then we start another medication. And he was like, yeah, I like that. So those conversations take a little bit more time. I'm not the kind to like go in and tell the patient like, oh, your A1C went up, you need more medication, you need insulin, or you need that. It's patient-centered, and a patient-centered approach, I guess. It's the real name for that. So that's kind of how the morning would go. Then it's a lunch break. It really is any time between 12:30 to 1:30. It's not like I have a lunch break, because I might just sit down, eat, and then keep seeing patients. Like I said, sometimes throughout the day, I would review some lab results, taxes, insurance paperwork that needs to be signed. There's a lot of that in your practice as a provider also. It's not just seeing patients. There's a lot of like the back office, I guess you can call it. And then go back to seeing patients. Telemedicine is something that we don't do a whole lot right now where I'm working, but we do some of it if a patient has been recently diagnosed with COVID. That really is the only time when we do telemedicine, because the patient population I see, there's a lot of chronic conditions and they just need to be seen in person. So we don't do a whole lot of telemedicines, but if we have some, I might do them at the end of the day. And then usually by 5, I'm ready to go home. So what types of appointments do I have? Like I said, a lot of blood pressure and diabetes follow-ups, women's health, so that's pap smears, pelvic exams, birth control. So we do the depot injections. We don't do IUDs right now in the office, but that is the plan for me to be trained in IUD insertions. I'm really looking forward to that. Lots of follow-up appointments for blood results, education, the next steps. So if, for example, I had a patient with abdominal pain that maybe needed a ultrasound or maybe needed, colonoscopy or endoscopy, then we would send them out and then have them come back when the results are back so we can talk about it. Lots of annual well visits. So even if the patient says they're just coming for follow-up, we're going to go through their whole chart and see what else they need, and always take that time to educate the patient. So med refills, sick visits, sometimes we're not, and if you follow me on Instagram, you might have seen this. I think yesterday I was saying we're not an urgent care, but again, for the patient population I work with, we tend to be their urgent care. So they come to our clinic. We had a patient that couldn't breathe, literally couldn't breathe, and she went to clinic instead of going to the ER. She was pale, bluish. We gave her a shot of epinephrine. We put her on a nebulizer because she couldn't really talk a whole lot and tell us what happened. The nebulizing machine wasn't really working for her. She felt like the air wasn't going through. We had to call EMS and send her out to the hospital. So we have some of those visits sometimes. Again, it's kind of what you would see in an urgent care. Sometimes ER and hospital follow-up appointments. So if my patient was hospitalized for pancreatitis or an MI or whatever other issue, then they should follow up with their primary care within about a week or two. Sometimes they don't follow up until like a month later, but that's okay. We see them and talk about all those things too. Some of the common chief complaints I see, lots of pains, of back, shoulder, knee pain, headaches, cough, suspected UTI or STDs, regular checkups, a rash, a lump, which a lump could be a ton of different things. New patients are also, we're having a lot of new patients because, which is really cool. And why I took this job is that they didn't have a female provider, and it's a heavily Hispanic population, which I guess those two things. So they didn't have a female provider, which really sometimes is needed because culture, right? And female patients might prefer another female provider. And lots of the patients there are Hispanic, and they didn't have a provider that spoke Spanish. So this rotation, or this place where I worked, was one of my rotations. And I just loved being able to help the patients in their own language because they felt understood. There wasn't a language barrier anymore. And that was just really cool to me. It's very satisfying, and it's just, I guess, very satisfying. So I talk Spanish, I speak in Spanish pretty much like 80% of the day because RMAs are also Hispanic. So it's just a huge Spanglish sometimes. Even with patients, I would go in a room and I would say hola because their name to me, is Hispanic. And then they go, oh, hello. Okay, so we talk in English. And then I come back again and then we're talking in Spanish. So it's always confusing, but it's also really fun. So I have a few case studies here for you guys. Case number one, these are just some examples of what, a typical day might be like. So 48-year-old female with I always like to look at the chart. I don't think I mentioned this already, but we don't have EMR where I'm working. We have paper charts. And I'm not sure when we're going to go into EMRs because just a lot of different things, issues, but we have paper charts and they do a pretty good job at keeping all the information in the charts and all the health maintenance stuff. So I typically would look over that and, get familiar with the patient since I'm a new provider. I haven't seen a lot of the patients before. Now that I'm going into month 3, I've seen quite a few patients more than once, so that's really nice. But either way, I look through the charts, see what they were there for the last time, look at their medications, their medical history, see what they need. So, okay, she says she's here for a med refill. Okay, next, I see that she is due for an annual well visit. So what should we address today? I'm going to go over her medicine. So this is a list of this kind of an example, and sometimes their list of medication is actually longer than this. sometimes it's smaller. But my point with this is the med reconciliation is really important because sometimes patients take medications that they don't even know what they're for, or they don't know the names, they don't know the dosages, they only know, the pink pill or the little round white pill or the one that's huge and I only take it, once a day or something like that. I am working with my patients on having them create a written list of their medications and what they're for. Sometimes I have them bring all of their bottles to the office and we go over one of each of them, and I will write on their bottle or on a piece of paper, metformin and glimepiride and Lantus. These 3 are your diabetes medications. So we kind of do that. And then sometimes I found out that they are not taking, let's say their omeprazole, like, oh, I don't need that anymore. They give me that when I was at the hospital. I don't even know what for. I don't take it. Okay, so let's just take that out of your list. How about the Celexa? I don't really take the Celexa. I don't really like it. I take my Xanax, more often when I need it. So then that's another education point, is how do benzos work, and anxiety and depression, and we talk about that. So then after that, sometimes again, these visits take a little bit longer. I'm very lucky because as a new provider, I kind of have more time to spend with my patients, and I don't have a number of patients that I need to be seeing right now. So I get to sit down with them and go through these things. Now, I may not be, so extensive every visit, but every now and then, this is good. We would talk about their sugar monitoring. Are they checking their sugars at home? What are their blood sugars like? Their goals, hypoglycemia. We do a little bit of education on that. Talk about health maintenance. So if they need any vaccines, if they're due for pap smears, mammograms, colonoscopy, routine labs. We talk about diet and exercise. So, and I have just 3 things. I should have edited that out, but I guess this kind of shows how important these 3 things: diet, exercise, pain, and mental health are. Always talk about those with my patients. So that's what a simple visit, right? Because they said, oh, med refill. Then it turns on into a lot more things than just a med refill. Here's another case, and I hope I'm not going too fast. Case 2 is a 60-year-old male. He has a history of uncontrolled diabetes and hypertension, hyperlipidemia, and he's here for check his privates for a rash. So he's complaining of a itchy rash on his penis times 1 week. He was waiting until his med refill appointment to have it checked because, maybe lack of transportation. He says there's a little bit of some discharge and some red spots, but he hasn't had any fevers, no urinary symptoms, no pain, and he's not sexually active. So I'm not reading the chat right now, but this is just to kind of get you thinking. And I should say this because when I hit next, everything is going to show up. I am not the best at the putting one thing at a time. I need to work on that, but okay. So here, next we're going to drape the patient. We have to take a look at it. Anytime there's a complaint, like, a lump or a rash or something like that, you have to look at it. So this is what we're looking at, right? So we know, or you should, in your education, you know what a healthy penis looks like, and then his looks like it's red. There's a little blotchy rash. There is a little bit of discharge. So I start to think of what could this be and what are his risk factors. So for people that have diabetes or uncontrolled diabetes, or somehow they have a decreased immune system, they're going to be more likely to have yeast infection. So in males, that's going to look like Candida balanitis. And in females, that might look like a yeast infection and a UTI. So based on that, we make our diagnosis and we educate the patient, right, that he has a yeast infection and he is going to need antifungal and good hygiene and good blood sugar control. And he should be back in about 10 days or so if it doesn't get better. We also take some time to talk more about their diabetes and look at the medications and see what he's doing with his diet and all that. All right, the next case is a pain case. So I thought I would put this here for you guys. This is how to assess for pain, and it's a little mnemonic, very common. It's OPQRST. So the O stands for onset. We want to ask our patient, when did the pain start, and what were they doing when the pain started? P is for all the provocative or palliative factors. So again, what were they doing when the pain started? What makes the pain worse? What makes the pain better? The quality, so this is it throbbing? Is it sharp? Is it dull? You know, pins and needles, that kind of thing. Radiation, so we want to know where does the pain go, or if it stays at that location. The severity, so we'll tell them, you know, in a scale of 1 to 10, 10 being the worst pain that you've ever had, where would you rate this pain? And then the time. So again, we ask about how long have you had this pain for? Have you had this pain before? Does the pain come and go, or is constant? So now as far as our actual case study, the patient is a 67-year-old male. He comes to the office with, well, he has a past medical history of arthritis in his right knee, nothing else. And he comes to the office for abdominal pain. That's all I know so far. He, as far as medications, I know that he has some tramadol that he was prescribed a few weeks ago. He was only given a few of them, like 10 or so, but nothing else. But I go and talk to him. Patient says the pain is intermittent, so it comes and goes, and he's had it for about a month. It's diffuse. Sometimes he feels it at the top of his stomach, feels like a burning sensation. He says it's worse when he gets upset or after eating some foods. It kind of resolves on its own. He doesn't really take medications other than what he had for the arthritis and some Motrin here and there. But the pain really has gotten worse in the past 2 weeks. Last night it was really, really bad, and he said he was about to go to the hospital. He didn't. Instead, he took some tramadol, which is a pain medication that he was prescribed for his knee. And that seemed to work really good, so that's why he didn't go to the hospital. Now, this morning, he thought he would have it checked out. So let's see what else. Try to think of what things we need to be asking him. There we go. Okay. So we ask about his diet. He eats a lot of Mexican foods, a lot of fried foods, doesn't drink a lot of water. He hasn't had any nausea or vomiting. He says bowel movements are regular, no diarrhea, no constipation, no blood in stool, no dark stools or anything like that. But he says last week they were green. Once last week they were green. He's voiding okay, but he felt like it was kind of red and just dark this morning. Otherwise, no complaints. He's a non-smoker, no recent travel, no regular medications other than what we just discussed. We take his vitals and everything is pretty good. His physical exam is pretty benign. There's just some diffuse tenderness in his belly, but his positive bowel sounds. We are looking for, you know, signs of inflammation of the gallbladder, the liver. We're looking for irritation of the colon, and nothing jumps out at us. His pulses are good. So what do we do with this patient? What can I do at the office? Again, we're in family medicine and we can do some testing. We have a lab, but we can only get like a stat CBC, which would tell us about infection. I don't have ultrasound available until like the next 2 days. So 2 days later, I can take an EKG, I can take chest X-ray, and I can do a urine dip.
Some people said stool sample or urine sample.
A stool sample?
Yes.
Or urine sample? Yeah. So yes, we're gonna check his urine, have him get a urine for urine dip. Okay, here we go. So we start to think of the differential diagnosis, right? And even though this is family medicine and he's just coming with abdominal pain, we always just want to rule out an MI. You just always never know. Always never know. That's kind of weird. You just never know. And it can present different in different people. So we can do that with the EKG. And you would do in the emergency room, you would do troponins, but again, I don't have that option at the clinic. We're thinking of biliary tract disease, those green stools and the dark urine kind of point at that. We're thinking of kidney stones. The pain for kidney stones, usually, right, we are kind of used to thinking of the CVA tenderness, that's the back pain that kind of goes down. But again, it can present different in some people. And then some gastritis at first, it really looked like that because you said it's burning sensation, it's worse with some foods. But then it got a little bit more complicated. So we got the EKG, and I think I might be going into the next slide too, but we get an EKG, we get the stat CBC, we get our urine dip. We get some more lab work, but we're gonna send this out, so we won't have that result until about a day or two later. And we send out for a UA also. And yes, we need an abdominal ultrasound, but when do we need that? Do we need it now, or do we need it in 2 days when the ultrasound tech comes to the office? So in his EKG, everything looked great. His stat CBC was pretty normal. The urine dip, this is what it showed. The urine was red. I looked at it and I thought again, I'm a new provider and there's always a learning experience and we're always learning. But my first thought was, oh, this is blood. The urine is so red. Well, his bilirubin was 3+. Bilirubin can also show as dark red, kind of just dark urine. And then he could have been having a little bit of a UTI as well. But he needs an ultrasound now. So this patient is going to have to go to the ED. I advise him, you have to go to the ED because they need to do more imaging. The concerns right here is cholangitis. So basically him, and I think I have a slide to explain this better. Yeah, so a little bit of anatomy review. So we have our gallbladder right here, and we know that we can get stones, and that's, if it's just a stone and they're sitting there, it's called cholelithiasis. When that stone starts to move and it starts to, it gets stuck in this little duct right here, that's when it causes a lot of pain because it's stuck and it gets infected, so it can cause some fever, and this is called cholecystitis. So what they would do for this is they can remove it different ways. They can do a laparoscopy, or they can go in and take it out. Sometimes they will wait and see if it's just it could be like a biliary colic, so it produces pain but it goes away. So, but that's not too life-threatening. Now, if that stone keeps moving and goes into this longer duct that's called the common bile duct, now it starts to become more of a problem. So that's called cholelithiasis. And so patients typically will present jaundice, so they will look a little bit yellow, and their sclera can be yellow also. Their liver function tests are going to be high. And then if it keeps going down and it's trying to go into the duodenum, but it gets stuck, then that's called cholangitis. And that's life-threatening. There's a a lot of issues that can come here. So that was my concern. That, you know, eventually if I waited for him to have that ultrasound 2 days later, that if he had a stone and it kept moving, that is what could have happened. So sure enough, patient went to the ED and he ended up being in the emergency, or he ended up being admitted, and he was hospitalized for close to 2 weeks because he did have a stone, and it was so big, it was stuck somewhere up here, but it was so big that when they did the procedure, it's called an ERCP, a really long name, but they basically go kind of backwards here to try to take that stone out. Well, it was so big that they couldn't take it out. And then his liver enzymes, his bilirubin started to jump off, and it was too high. They had to wait until that came like back down on its own for them to be able to cut him open, because when they did that procedure, that didn't work. So then they tried to do a laparoscopy, and again, the stone was still too big, so they couldn't do that. They needed to take the whole gallbladder out, and the gallbladder was just too big. So then they had to cut him open to be able to take the gallbladder. So he came back to the office probably like 3 to 4 weeks later. And it was really nice because he was thanking me, you know, that I sent him to the hospital right on time. That's what his provider that saw him at the ED said, is like, hey, you know, the doctor, whoever sent you here, they did good, because this could have been really, really bad and you could have died. So they saved your life. And I was like, oh, this is really reassuring. And this is one of the great things about family medicine and about just, you know, working in medicine and being passionate about it. And if you don't know, if you're in doubt, you ask. So through this process, I did have one of my PAs that, one of my coworkers who's also a PA, and I'm just, you know, bouncing ideas off of him, and we're trying to think of what else it could be. And so, you know, we came up with this diagnosis, and that he needs to go to the ED like now. So that was that case. I wish I could share a lot more, but you know, we only have so much time. I don't even know if I'm past the time, so I'm sorry. But that's it for now. Let me know what the next steps are.
Thank you so much for that. We're going to do a question and answer. Students, if you can drop your questions in the chat, we have quite a few that we're going to go through. The first question is, how has your experience as an RD influenced the way you practice right now?
That's a great question. It has, in the sense that I make sure to spend time talking to my patients about their diet, and little change, just make it really simple, and little changes that they can make to help, whether it's their high blood pressure or their gastritis, their Crohn's disease, you know, their diabetes, of course, but in small changes and a little bit more accurate advice. That, like, when I was working as a dietitian, I would get patients telling me that their provider, you know, had them stop all kinds of foods that didn't make sense for them to stop. And it just infuriated me a lot, because, you know, someone that was maybe pregnant and had diabetes, and the doctor told her that she had to stop eating all kinds of carbohydrates, no more bread and pasta, and no more fruits, and no more milk and whatever. Well, that's not how it works. They still need the carbohydrates. So you know, having that background really helps me explain that and make it simple to my patients, and work with them and assure them, give them a little bit of reassurance that they don't need to, you know, eat like organic foods and a certain way to take control of their health, and we work on it. So it has helped me a lot in that sense.
Thank you so much. Our next question is, what are some of the ways that a PA can expand their scope of practice once they have been working for a while?
That is another great question. So I think that there is a lot of room for expansion, especially when it comes to the specialties, right? Because some of the skills that you earn, so for example, me working in family medicine, I am getting a lot of skills that I could then go and use in maybe urgent care, and I could then use some of that too and expand and work in emergency medicine, or I could go a totally different route and do the OBGYN part or endocrinology. And you get a lot of on the job training. So as the years go by and you have experience in, a few different fields, that helps you expand your scope of practice. And you can also always, with CMEs and additional certifications like the CDE or the diabetes education, there's also residency programs. If you're really interested in one particular area that is available, it's not required, but it's certainly out there. So there's like an ICU residency, there's emergency medicine residency for PAs, and that can also help you kind of get more skills and confidence in that one particular area. I hope that answers that question.
Thank you. There's a question in the chat asking, what made you become interested in the dietitian or nutrition in the first place?
Oh, yeah, I didn't say that. When I was in high school, I only knew I wanted to work in healthcare. That's about all I knew. I did a what's it called? An not international student, exchange. I went to Utah and I lived with a host family for a whole year. And I went to high school in Utah. And when I was there, I had the opportunity to do two internships with a dentist, so a general dentist and an endodontist, because I thought I also wanted to be a dentist. And when I did that, I found out that I hated it. I hated working in the mouth. And even though I really enjoy having straight teeth and a good smile and things like that, I just couldn't do it. So then I went back home to Venezuela, and that was one of my plans was to apply to dentistry. So I didn't. At some point, I had talked to my biology professor, biology teacher in high school, and she was a dietitian. So she was the first one that told me about that profession. And again, I did a little bit of research. My aunt, I had an aunt that had kidney disease, and she was working with a dietitian. So that's for her dialysis, because it's very tricky in terms of what you can eat and, electrolytes and micronutrients and things like that, vitamins and minerals. So kind of all of those things pointed me towards dietetics. I wasn't really sure about it until I actually started in my first year, when I took like intro to dietetics and some anatomy and some biology and things like that. That's when I thought, oh, I really like this, and there is so much that you can do as a dietitian. So that's how I came into that decision.
Thank you. Our next question is, what do you think made you stand out most on your application to PA school?
I think it was my experience in dietetics, because while there are more dietitians going to PA school, it is not very common still within the pool of applicants, right? There's a lot of people with backgrounds in maybe EMT and phlebotomy and MA, CNA and things like that. But I think that experience and that, I guess the experience of working in diabetes and managing insulin, I think that's what made me stand out.
The next question that we have is, do you have any tips on getting through a hectic workday?
Tips on getting through a hectic workday. Coffee. I think that as long as you like what you're doing, It's going to be okay. We've had very, like, yesterday was a crazy day. We saw 60 patients, and it's three providers. That might sound, depending on what kind of background you have, that might sound like too little, because people say in urgent care, they might see like 70, 80 patients. But the urgent care visits are faster, and it's, maybe like a COVID test or strep throat, and off you go. In family medicine, there's a lot more for each visit. So that was like a very busy day. And then you add like procedures. Yesterday, this is what I wanted to tell you guys, is like my day started with patient, he came in for med refills. And then he tells me, well, I've also had blood in the stool, last week. Oh, okay, well, that's kind of important. So we needed to do a rectal exam. And then the next patient was this patient that had a lot of, she had her period for like 2 months. So that ended up turning into a huge thing too. Then a patient with a lump in her breast, patients with diabetes, like uncontrolled diabetes, patient with an abscess. So days like that are hectic, if you're doing something you like, that will make it a little bit easier. But still, every now and then, it's important to take some time and just breathe, drink some water, eat, stretch a little bit, and keep going. And if you need coffee, or if you need to talk to somebody and vent, do that too. And then when the day is over, when the work day is over, then it's over. Then go and do something that's going to give you some energy back or some peace of mind, whatever your cup of tea is. So whether that's working out, going for a walk with your dog, or watching Netflix, or going straight to bed. But always try to pour back into your own cup, if that makes sense, because otherwise you cannot pour from an empty cup. So I think that's something important, something I am definitely trying to work on to help prevent early burnout, because burnout is real in school and grad school, and then in our professional life too.
Thank you. Our next question is, can you describe your first day of being a PA? Were you expected to see a lot of patients by yourself?
I love this question. It was frightening. It was overwhelming. It was super exciting. It was all the things at once. No, I was not expected to see a lot of patients on my first day. So like I said, my job, I did actually 2 rotations there. So I already knew the staff and my coworkers. I kind of knew that was actually my second rotation and my second to last rotation too. So I was very familiar with the flow of things. So in that sense, my first day was probably different than for a lot of people, because I had some experience there as a student. But as a provider, no, I kind of was on my own, and I didn't necessarily have to have it, my preceptor sign off on my charts. But trust me, I asked probably more than one question for every single patient I saw, because I just didn't know, and you don't feel confident. You are this, well, also huge point to make here. My first day as a PA, I was a PA. I was not a PAC, because I had taken my PANS on the 26th of August, and I started working on the 29th, but I didn't have my results yet. So I did that thanks to having a temporary license, and that is different in each state, but in Michigan, you can do that. So I started working with a temporary license without knowing if I had passed my PANS. So that was just weighing in my head all day long. I felt like a huge, imposter syndrome was just all over my head, because I'm like, I don't even know if I'm a real PAC. And here I am, like, telling this patient something about their blood pressure medication. But then the very next day, my results came in before I started my shift, and I had become a PAC. But yeah, it was just very exciting and very nerve-wracking, overwhelming. I felt like I didn't know anything. I had to use like UpToDate a lot and ask a lot of questions. And then I came home not quite feeling frustrated again, but just overwhelmed. And I talked to my husband, who's like my main support system. I talked to some new grads and PAs as well, and they all just told me the same thing. That is 100% normal, and that feeling will last, 6 months to a year until you start to feel more confident, until you start to become more familiar with the medications and the procedures and the processes that like the systems that are in place at your clinic and things like that. So fast forward like 2.5 months, I feel a lot better. I'm not yet like 100% confident, but I do feel a lot better. I don't come home like that anymore. So it gets better.
That's good to hear. The next question that we have in the chat is, how much time do you spend with patients compared to non-patient work, like charting or ordering labs?
Can you say that one more time? How much time I spend with patients compared to what?
Non-patient work, like charting or ordering labs.
Oh, I spend probably 80% of my day is patient contact. We do paper charts. I try to do my charting in between patients. So like while I'm waiting, for them to get their x-ray or their EKG or whatever, I'll start my charting. And if I'm busy with like 3 patients at a time, then I just kind of pile them and work on them when the day slows down or through lunch, or I stay a little bit later or come up the next day. But really, most of my day, like 80-90% is patients contact.
Our next question is, how did you study in PA school?
It varied for each class and each semester. First semester was really overwhelming. You're kind of figuring out what works for you, what doesn't. I graduated undergrad like 3 years prior, but the year before starting PA school, I was doing all those prerequisites and studying for like my CDE. So I at least was kind of fresh in, studying. But it was different in PA school because each class needs different effort. Clinical medicine is one of the heaviest classes and where you have to put a lot more emphasis. I need to use all of my senses. So I would watch videos, whether that was YouTube or Osmosis was a resource that I used a lot. Reading, you have to read, period. I don't love reading, and one of the books that we used in school is Current, and it's a horrible book. I'm sorry if you come across that book because it's just so confusing. I hated it. But it's what we had to do, so I would just look for other resources, and I used a lot of pants prep pearls, Smarty Pants, so just kind of resources that are out there for students. And from all of that, I would make my own study guide. Sometimes I kind of made my study guides on a Word document on the computer, nothing fancy like you see now with, people doing all this amazing stuff on their iPad. I am not that tech savvy, but I need to write it down. So I probably wrote down the same, medications and diseases and things like that, like 10 times throughout, 100% more than 10 times, but I wrote things down a lot, and I had multiple study guides. And if I came across one topic, so like say we go over dermatology and didactic, well, when I went through different dermatology topics for my rotations, every single time I would still write things down again. So it's not like I would go back to use my, didactic year study guide. So I would just create a new one basically. But that, and then listening to podcasts on my way to on my commute, and writing things on a dry erase board. That's kind of what helped the most. just writing.
Thank you for that. There's a question in the chat. How has COVID affected your day in the clinic?
Well, my day in the clinic, all I've known is COVID, pretty much, because, well, that's a little bit of a lie, but also most of it is true. Because this family medicine was my second rotation, this was back in October of last year, and of course we didn't have COVID, so that, I guess that's the only point of reference that I have, because since I started working, we've had COVID. But looking from now to back then, honestly, the difference is the protective, like the PPE and the mask and the face shield, and the office is doing a lot more cleaning in between patients and things like that. Now we have the telemedicine that before we would never do telemedicine. And so now we do that, and a lot, maybe more sick patients, I think, because the COVID numbers are going up, but it affected more of my rotations because I was pulled from rotations in March, and then I had to stay home and I had to complete some rotations online with, kind of fake patients. And then I didn't get my full experience. Like, I didn't really get an OBGYN rotation because it was an online program, like an online rotation. I didn't really get an emergency medicine rotation because ERs were not taking students. I ended up getting a urgent care rotation instead, which was good, but it's not the same. So that's kind of how COVID affected my PA journey, I would say.
Thank you for that. Thank you for sharing. The next question that we have is, as a dietitian, have you found that people's socioeconomic background can limit their ability to afford or access healthy food?
Both jobs that I've had as a dietitian, when I was at the diabetes program and now, have been in underserved communities. I think, I don't know if it was just destiny or what, but I really like it. I'm very passionate about it. And so I've always been, I guess when I was at my first job, my population was a little bit more, there was a little bit more variety in socioeconomic status, but for the most part, it's been of low socioeconomic status. And so I have become maybe more educated and a little bit more well-versed in being able to provide patients with options that are affordable for them. So if when I was seeing pregnant patients, I would refer them to the WIC, which is the Women's and Infant Health Program, and thank you for bringing that up because I don't do it that much here, but I would refer patients a lot to like the food bank, and we had like a food pharmacy is what they call it, the hospital that I was working at. So I would use a lot of those other resources, and in terms of what they could afford to eat, I had lists of foods that were affordable, things that they could eat that were still healthy and you could say diabetes friendly, I guess. But that they could find like, at the dollar store, or canned foods are usually very affordable and they can be nutritious too. The problem is their preference, because a lot of the times, and it's just very unfortunate, patients will rather spend I don't know, $5-10 at like McDonald's and get a bunch of fries and a huge Coke than use those $10 like at the dollar store to get other kinds of foods because they just don't like the other kinds of foods, So that's where I would struggle the most, not so giving them options in terms of healthy foods, but their own preferences.
Thank you. The next question that we have in the chat is, how did you prepare for your interview, and do you have any tips?
Yes, I used two books, and I can't think of their names right now, but I think one book was like How to Ace Your PA School Interview or something like that. And that was one of the resources I used. And just going online and all this, right now, you guys are at a huge advantage because there is so much content online and there is a lot of free resources. You know, you can find a ton of different blogs and videos on YouTube and podcasts with tips to prepare for your interview, questions that you should be practicing for. There's like this coaching things that you know, some of them are paid services, but you don't, I didn't pay for any services other than having my PA statement, like personal statement, reviewed once. But for everything else, I just use that one book and I try to come up with practice answers to the most common questions. So, you know, behavioral types of questions where they would ask you, tell me about a time when you had a disagreement with your supervising physician and how did you handle it? So you can look up lists of questions like that. And then for each of those questions, try to come up with a list of things that you can answer. Situations, you know, sometimes you might need to like tweak things a little bit, but not lie, but just, you know, present them, like think them through a little bit more so you can answer the question. But I always I learned this method from my husband actually. It's called the STAR method, and I use that to answer my questions and try to come up with the situations. It's the S is situation, T is for task, the A is for the action you took, and then the result. So if they ask you something like that, then you can think of, okay, what was the situation? Well, my doctor told me this and I wanted to do that. And what did you have to do? How did you do it? How did you approach that? And then what happened at the end? If you do that, you're like almost 100% guarantee that you're gonna answer the question. You're not gonna get off track and start to like wander around, and you're gonna end it on a positive note, or at least that's the goal, you know. Even when they ask you about weaknesses and things like that, you always want to turn those weaknesses into a positive thing, something that you've learned. And also never say, oh, you know, I don't have any weaknesses, or like my weakness is that I am a perfectionist, because that's you know, very generic, and it just, you want to think a little bit more into it. But always turn your strengths or any kind of negative connotation or points into a positive, because you always can learn something about it. You always can improve, and you've probably done it even if you don't realize it. So those would be my interview tips.
Thank you so much for an in-depth presentation about your journey and answering our questions. For the final question, do you have any last-minute advice for pre-PA students or pre-health students in general?
Yeah, I would go back and say shadow people in the profession that you are interested in, and don't make somebody said this, and I read it on a post on social media and I couldn't agree more, is don't make your decision based to go for one profession based on what some other healthcare professional told you about. So like, and I've had people too say that they want to go, you know, into PA based on what a nurse practitioner told them. Well, we got to go back, and you got to make sure you understand each, you know, path and each profession, their roles, and you want to try to shadow or be exposed to it more than once. So, you know, not because you had a wonderful PA or NP or doctor that treated you when you were a kid, and they were the best provider you've ever met. That's amazing that you had that experience, but that doesn't really justify your decision to go into that specific profession, because we are, at the end of the day, they're all healthcare professionals, and they all need to be caring and compassionate and have empathy. And so those qualities don't make a profession, if that makes sense. You know, You want to look a little bit more like farther than that and see like things like the specialty and your own personality in terms of like, do you want to be the one that has the last say? Do you feel comfortable, going for advice and having a supervising physician, or do you want to be the one that people come to? So things like that is what you have to look at. Are you going to be able to commit to one specialty, or do you want to jump from one to another one? Do you like the medical model versus the nursing model? So things like that for sure when you're looking into what profession you want to go into.
Thank you so much, Gabriella. That was a wonderful shadowing session, and I'm sure that all of our students have great notes for their future. To all of my students, I have an announcement for you all. Please help us keep virtual shadowing free. This is a different QR code that I'm showing you, and this actually brings you to our join the fundraising campaign. And so this isn't asking you to donate, but rather to help us share. And so I am asking all of you to send this link out to 5 other people, whether this is your family, whether this is your professors or your friends. Please share this link. This is the only way that we are going to be able to get the funds to maintain our website and keep it up for you guys. And so we really appreciate any shares, any donations that we get. And we're really trying to have enough money to keep our program afloat. If you guys are interested in gaining professional opportunities and experiences and professional leadership opportunities, you guys are welcome to apply to our student team. This is 100% remote and is a great opportunity for you to learn about different types of fields that you might not necessarily know. For example, a lot of things that we're learning right now maybe are in marketing or in business or in communications. And so things that potentially STEM majors don't necessarily have skills like this under their belt. So it'd be a great opportunity for anybody who's interested in diversifying their skill set, as well as gaining some great leadership for your applications. If you feel that you do not have enough time to commit to pre-health shadowing because you are a pre-health student and you have a lot going on, that is more than okay. We do have volunteer opportunities available, and this is awesome because it's 100% remote. You can work on your own time for as little or as long as you want. So if the only time you have is at 4 in the morning, you are more than welcome to help out at 4 in the morning. So all of these links are on our website. I have linked QR codes here that'll bring you directly to the page, but you can find this under the contact tab in the main menu. Be sure to never miss an upcoming shadowing session. You can follow us on Instagram, Twitter, Facebook, and TikTok for awesome content. I have a challenge for you all today, and that is to go to our Instagram page, to Gabriella's post, and on the comments, I challenge you to comment her last name letter by letter. This is really difficult just because of the way that Instagram works, so getting it in order is a big challenge. So I urge you all to try this out. For anyone who happens to be successful, we'll be picking a student to be the spotlight student of the session. Don't forget to tag us in your posts and use the hashtag pre-health shadowing to get the opportunity to get reposted on our official pre-health shadowing account. We are active on TikTok, Instagram, Facebook, and Twitter. So be sure that you are sharing this opportunity. Like I said earlier, this isn't a secret. We're open to everybody and we welcome anyone who is interested. And so just be sure that you're doing your part and helping those people who don't know about us yet. Our next shadowing session is tomorrow at 4:00 p.m. Pacific Standard Time. Now, last but not least, to get your certificate that verifies your virtual shadowing hours for today, you are going to go to our website and you're going to go to Gabriella's profile page under courses. To the right of her picture, you're going to see free take this course. Once you click that, you will have 30 minutes to complete the assessment, and you have 2 tries to get a 70% or higher. Once you pass with a 70%, you must return to the speakers page and click the Finish Course button. Once you do this, you will receive your certificate and you can download it immediately, or it can always be found in your profile under the Certificates tab. I urge you all, since we do have a lot of students in this shadowing session today, please space out your quiz time. Please try not to go directly after this shadowing session as it might crash. We are looking to get more donations, so hopefully in the future we can avoid the website from crashing. But I urge you all to perhaps wait 15 minutes, maybe wait 30 minutes, try back in an hour if you are unable to take the quiz. If you're unable to take it in 24 hours, you can go ahead and send us an email at info@prehealthshadowing.com. The quiz will remain open indefinitely until further notice, and so please do not worry if you're not able to do it immediately. We are trying our best to keep the website up and appreciate all of your guys' support. So that is all I have for you for today. Thank you again to our wonderful speaker, and thank you to all of our students. This concludes our virtual shadowing session, and I invite you all to disconnect from the call.
Thank you so much for having me. You guys are doing a great job with this virtual shadowing session.
Thank you so, so much. It's amazing to just be able to have your support, and we're just so grateful that you're volunteering your time with us. And so just thank you again.
Of course, anytime. Have a great night, you guys.
You too. Bye-bye.
Thank you.